Good afternoon, all. We have seen about the history, physical examination, all, and the pre and post operative management in gynecology. That is the major and minor. So, we are coming to the disease condition, how the surgery has occurred. That is the major pre and post operative management we can do in each condition. Okay, coming to the retroversion of uterus. Retroversion means that is the normal, from the normal position there will be change in the uterine position. So that is called as the retroversion of the uterus. So we can see the supporting factors of the uterus. Many factors are supporting the uterus. What will be the factors? That is the position. Normal position of the uterus is anteverted, anti-flexed position. Anteverted means that is about the 90-degree angle. That is the whole uterus makes right angle with the longitudinal axis of the vagina. That is longitudinal towards the axis of the vagina. That is 90 degree. It is anteverted. Anti-flexed, that is 170 degree it will be flexed. That is also longitudinal axis towards the cervix. Okay, that is the normal position of the uterus. In that, coming to the retroverted flexion. Retroverted flexion means we can see the first retroversion. We can see the definition. Retroversion. It is the term used when the long axis of the corpus and the cervix are in a line. That is, the corpus and the cervix are in the same line. That is called as the retroversion. And the whole organ turns backwards in the relation to the long axis of the birth canal. The whole part of the that is the uterus is turned back towards the birth canal. Backward, the uterus that will be turned backward. You see, the normal position, you see, normal uterus, that is the towards forward it has been flexed, and it will be, that is retroverted means it will be changed backward, that from the normal position towards the back side it has been flexed. Then retroflexion signifies that is the backwards of the corpus on the cervix at the level of the internal os. This condition, two conditions are usually present together and are loosely called retroversion or retrodisplacement. If any question asked retrodisplacement, you asked, retroflexion asked, retroversion asked, any of the question comes, you can answer the same one. That is this is one type of displacement of the uterus. Okay. Clear, I think you make clear about the definition, how the uterus position has changed. The normal position I have explained, here also the figure is there, normal position, and it has changed. How the retroverted, the change of the uterus position has changed also, it has mentioned. That is the backward displacement of the uterus where the angles of version or flexion looks backward. Okay, next, coming to the etiology. That is congenital. Congenital we can say as another word, developmental. From the development, from the intrauterine life, that is the baby has born, from there itself we can see that one. That is the retrodisplacement is quite common, fetus and young children. Due to the developmental defect, it is the lag tone of the uterine muscle. Developmental defect, first one, the lag tone of the uterus, it may cause, and the infantile position is retained. That is, the infantile position may be retained. And also the second, it is also associated with the short vagina with shallow anterior vaginal fornix. Okay, that is the, then congenital asymptomatic. There will not, we can't find any symptoms, we can't see any symptoms, and no treatment is also needed. Then acquired. Acquired means due to three factors, that is the puerperal, pelvic pathology, prolapse. Puerperal means after the delivery. That is due to the childbirth fail to keep the uterus in normal position. That is the stretched ligaments. The ligaments, the supporting ligaments, the control or laxity of the ligament has lost. That is the stretched ligament due to the puerperal condition. Then weight, bulky uterus and soft LUS. Bulky means that is the uterus is in very bulky and soft. That is that uterine surfaces are left uterine surfaces are also soft. That is the other cause. Then pull, prolonged dorsal position. Pull, then push, long standing bladder distension. These are then pelvic pathology, that is the push fibroid, pull adhesions is there. Then fibroid, that is the anterior or posterior wall produces heaviness of the uterus, hence it falls behind. Then pelvic adhesions are inflammatory, that is occurred due to the pelvic endometriosis, that are the pulls the uterus and posteriorly. Okay, understood. This is due to the adhesions, that is the pull the uterus posteriorly. Then prolapse, due to prolapse, that is the cause or result of retroversion, retroverter flexion, there will be the prolapse of the uterus. Then types of retroverter flexion, that is the mobile retroverter flexion or fixed retroverter flexion. Mobile means that is the due to the laxity the uterus is floating likewise. That is fixed means there it will be the same position and it won't be, the uterus won't fold, it will be straight, looks backwards towards the. Then degrees, there are mainly 3 degrees are there, first, second, third. How the degrees we can see? In the first degree, fundus direction and external os direction, that also we can see. The first degree, the fundus is vertical and pointing towards the sacral promontory. The fundus direction is the vertical. In the first degree it will be vertical and it is pointing towards the sacral promontory. Have you studied about the pelvis? If you have studied the pelvis, you can identify the where is the sacral promontory. Otherwise, if you have not studied about the pelvis, I may explain about that one. That is how the sacral promontory may occurs. That what will be the position of the sacral promontory? You imagine that is the pelvis. Pelvis, vertebral, that is coccyx vertebra, that is vertebra fused 5 vertebral bones are formed. In that uppermost portion, sacral promontory, that is it forward towards that, this is the sacral promontory. So the fundus, the vertical and pointing towards the, that is the fundus of the uterus, that is pointed towards the sacral promontory and downward, it is flexed downwards. Second means that is the fundus and sacral hollow, but not below the internal os. That is the between this fused vertebrae, not below the internal os. Forward. Then third, the fundus lies below the level of the internal os. That is the sacral tip, up and forward. If you are getting the pelvis picture only, you may study reveal the part of the pelvis only correctly. You know the part of the pelvis only, you may understood this degrees of retroverted flexion. Then diagnosis, we can diagnose, that is the here, that is we are clinically we can diagnose how it will be the occurs. Symptoms, the 50% of cases asymptomatic. Symptomatic means the pelvic congestion symptoms. Then pain, low backache, pressure on uterosacral or pelvic congestion, dyspareunia, ovary, uterus and pelvic congestion. Due to that, dyspareunia will occur. Spasmodic dysmenorrhea, cervical destructions and hypoplasia. Then infertility, complications during pregnancy, the abortion, incarceration, anterior ejaculation. These are the infertility means, that is the infertility, how it will be. The third degree retroversion, the external os is away from the seminal pool, that is the sperm wants to enter into the uterine cavity. No, the sperm is how the infertility occurs. I am explaining. The sperm is not able to enter into the uterus, the seminal pool, the posterior fornix during the coitus, or it may be occluded by the anterior vaginal wall. So, underdevelopment of the uterus may cause, that will be the factor of the infertility. So, in this condition, we should be think about that the patient is having infertility. What will be the symptomatic? Then related to backward position of the womb. Then chronic pelvic pain will be there. Dyspareunia will be there. In these all cases, we should be assess that. Okay. That is the pain. Symptomatic also you have understood. I think so. If any doubts you may arising, you can ask directly to me. Okay. Then signs of diagnosis are PV and bimanual. PV means per vaginal. We are inserting the fingertips. That is the posterior lip is the first to be felt. Direction of the external os, body of the uterus. Most common mass in Dougal's pouch. Uterine sound, confirm direction. Uterine sound is a device. That is the device to assess the measurement of the uterus and how where the uterus position also we can assess. Then next is the pessary test. Pessary test I will tell you. If these symptoms are there, we can insert a pessary and correct the position of the uterus. That is the pessary. Later I will explain how that pessary. Special investigations are ultrasound, HCG, lateral view. Okay, that are the. Then speculum examination also we are seeing, that is the bimanual, that is the cervix common views, that is the external os points towards. Then rectal examination helps to confirm the diagnosis. Okay, rectal examination we can see that is the your uterus fundal region is fully backward. By this we can assess the cases. Then differential diagnosis we can say, that is the causes of mass in Dougal's pouch. A mass will be felt on the Dougal's pouch. Deep dyspareunia, low back pain. These are the differential diagnosis. Then treatment lines. No treatment. If no symptoms are there, no treatment is needed. Prophylactic treatment during puerperium. Then active treatment. Fixed RVF, treatment of the cause. What will be the fixed? We have studied that 2 types of RVF are there, fixed and mobile. Fixed means that is the symptoms that arise on the fixed RVF are the menstrual abnormalities. According to the pelvic pathology, we can rule out. That is the menstrual abnormalities, menorrhagia, congestive dyspareunia, chronic pelvic pain, or dyspareunia are the main causes for the we can rule out for the fixed RVF. Then mobile RVF, palliative pessary treatment. Then operative treatment, positive pessary test is there. Then we can go for the operative treatment. Treatment of incarcerated RVF gravid uterus. Then prophylactic treatment during puerperium. Avoid full bladder. Then lying on abdomen 1 hour daily to encourage AVF, that is the anteverted flexion. That is in the correction of the flexion. Then postnatal examination after 3 weeks, discover RVF, pessary correction also can be done during prophylactic treatment. During puerperium, due to any puerperal causes it has occurred, we can correct like this. Then palliative treatment, Hot-Smith pessary. Indications, pessary test, puerperal RVF, then pregnancy RVF during pregnancy, that is during that 14th week. Then patient refuse, unfit, or has contraindications to operation. Certain cases of infertility when other causes were excluded. And also coming to the indications, that's the pessary test. pessary test is the less commonly used present day. In this present condition, pessary test is less commonly used, and in which all conditions for pessary test is indicated pessary test are subinvolution. In subinvolution of the uterus, subinvolution means after the delivery, within 6 weeks, the uterus will be fully revert back to the non-pregnant state. If the uterus is not returned back to the non-pregnant state, it is called as subinvolution. Involution means return back to the non-pregnant state. Involution. Subinvolution is not revert back to the non-pregnant state. It is the difference. Understood, I think so. Then puerperal, RVF, then pregnancy, then pessary test, how it is conducting. Pessary test is conducting same. Here this picture has given in your gynecological textbook. That is you see the figure first, that a tip of the finger has inserted with the help of the pessary. That is a uterosacral ligament also you can see. Then the second one, that is see full of the uterus that is flexed backward, that is retroverted flexion has occurred. And while the pessary is inserting, you see how the pessary is inserting downwards, that is towards the uterosacral ligament. The uterus position, that is the fundal uterus, is somewhat extending towards, coming towards forwards anteriorly. Then see on this, that is when the pessary inserted below their uterus, how you see again its flexion takes place. That is the uterus is bending forward anteriorly. Then on the fourth D, you can see that is the pessary is fully inserted and towards the uterosacral ligament, and you see that is it has situated in the normal position. You see how the pessary is inserting and where is the placement of the pessary. I think you may understood. Okay. Then surgical treatment. If the positive pessary treatment is good, then we can go for the surgical treatment, abdominal laparotomy and laparoscopy. That is a ventrosuspension. That is the multiplication and suturing of the both round ligaments, anterior rectus sheath. Modified Gillam's operation. That is the surgery that is we are doing for ventrosuspension. The principle of surgical correction is multiplicating the round ligaments both sides extraperitoneally toward the underside surface of the anterior rectus sheath. Okay, this will pull the uterus forward and maintains permanently in the same position. By this ventrosuspension, that this surgery if you are doing, that will be the pull the uterus forwards. That is the anti-flexed position, and that is the permanent method. Then ventrofixation, fundus suturing to anterior abdominal wall. That is the fundus only forward. That is bad posterior circulation during pregnancy. Baldi-Webster operation, round ligament passed through the broad ligament and sutured back to the uterus. Then surgical treatment, if positive pessary vaginally, open Douglas pouch, shortening the uterovascular ligament. Then open uterovesical pouch, multiplication and round ligament. Then surgical treatment is positive pessary test, inguinal multiplication of round ligament through inguinal incision. Then retrovaginal flexion, that is uterus, retroverter flexion, uterus and prolapse. Fothergill operation. Fothergill operation is carrying out in these cases. And also it gives the permanent cure. Then treatment of incarcerated RVF gravid uterus, catheterization of the bladder, manual correction of the uterus, mobile pessary till 14 weeks, mobile RVF means pessary till 14 weeks. Fixed means laparotomy to cut the adhesion. Okay. Thank you all.